Hello and welcome. Thank you for coming. My name is Jeff Light with HemoSonics, a Stago Group company. Dr. Bruce Wellman, MD, currently practices medicine at Carle, providing clinical services as a pathologist at Carle Physician Group and Carle Foundation Hospital in Urbana, Illinois. He's currently serving as medical director of the Carle Foundation Hospital Laboratory. This 560-bed regional medical center is part of the Carle Health, a regional integrated delivery system, which recently expanded significantly. Board certified in anatomic and clinical pathology, Dr. Wellman is also transfusion medicine and blood bank subspecialty board certified and serves as medical director at regional donor centers. Dr. Wellman served in an executive role as CEO of the multi-specialty Carle Clinic Association for 11 years between 1999 and 2010. Following integration with the Carle Foundation Hospital, he served as chief medical officer for the hospital and president of the employed 300+ member physician group. His interests include transfusion medicine and appropriate laboratory utilization. He has developed databases within the laboratory to contribute to identifying low-value care and has implemented numerous efforts to reduce inappropriate testing, to follow evidence-based guidelines, and introduced appropriate technology and clinician education to more efficiently use laboratory services. He served in the United States Army for 7 years, thank you, training as a pathologist and then serving on staff from 1974 to 1981, stationed in Honolulu and San Antonio. He graduated from the University of Michigan Medical School with an MD in 1974 and University of Michigan Bachelor of Science in 1972. Dr. Wellman, we're happy to have you speaking on this important topic. Welcome and thank you. Please take it away.
Thank you, Jeff. I want to welcome and thank all of those who have chosen to participate today in our presentation, and Jeff and I will be available for comment and questions at the end of the presentation. Healthcare is complex. It's constantly changing and resources are limited. And that's been true for 44 years of my clinical career. Successful delivery requires that we coordinate multiple parallel work streams, use appropriate resources for each planned and unplanned patient interaction. In order to be successful, we as leaders need to understand how these work streams communicate and interact to support the desired outcome in order to maintain performance levels and to implement change. An example of multiple, what I call work streams, would be an emergency room visit. An emergency room system has to have pre-hospital care and monitoring and communication with patients in transport and their caregivers. Once they get to the emergency room, numerous physician and nurse and other professional services need to be immediately available. The support of the ancillary structures in laboratory and radiology are critical. And then you have the whole larger organizational environment resources necessary to maintain a safe emergency room are critical. So the laboratory services is one of the many work streams, as I call them, in the care delivery process, and they provide critical information to support diagnosis, therapy, and monitoring of our patients. One of the major challenges we have is to deliver accurate results in a timely fashion to support the needed evidence-based clinical services wherever they may be given. Today, I would like to briefly discuss an opportunity to manage the use of limited resources and then focus on a specific application of technology and knowledge that benefits our patient by timely delivery of needed information and while minimizing people, time, and the use of other limited resources. Blood management is a process that has been under consideration and being evaluated for over 15 years. We recognized many years ago there was a great variation in the use of blood products and the intensity of blood products used for specific healthcare situations. Given that variability and no real proven difference in outcomes, it seemed to be an opportunity for improvement, reducing not only resource uses, but in making patient care more safely by minimizing transfusion risk, among other advantages. Into the patient blood management is a concept that integrates multiple work streams across the organization with knowledge to provide the optimum conservation of the patient's blood as well as evidence-based use of blood components. Combining efforts to engage the patient on both their understanding and acceptance of blood transfusion and its alternatives, reduce anemia, utilize blood conservation strategies and techniques to reduce bleeding and to minimize blood product use, and optimizing coagulation so that patients are less exposed to some of the risks of surgery or interventions and will require less support. In 2014, Carle Foundation was facing a challenge with rising blood use at a time when national blood use was declining. We initiated a process that evaluated our current state, implementing multiple databases. We looked at our comparison utilization to a peer group of hospitals, evaluated nursing and physician protocols, and basically we moved on to reviewing all the published guidelines for transfusion. Many of these are specialty specific and situation specific and need to be taken into account when developing your practice guidelines. So we developed a set of practice guidelines that reflected current best practices. We used these guidelines to develop our EMR order sets and created and did a number of other things. With all these interventions, we basically were able to show that we could show a reduction in our utilization that was significant, up to 45% of the total components transfused each year. During the implementation, we observed a direct reduction, and we had specific interventions focused on red cells and other platelets and plasma. And it shows that by coordinating multiple work streams and knowledge bases across multiple environments, we can achieve significant change. And I think that's one main point to make, is that you have to integrate multiple different work streams, as I call them. What's the surgical work stream, medical work stream, oncology work stream, and find out how they work and find out where we can intervene with information, with sharing guidelines, and through technical means such as an EMR intervention. Point of care testing is another technology that can save not just resource use and time, but it basically allows us to deliver actionable results at the point of care. That has significant advantages, and it reduces the time to translate those results into a patient intervention. Examples are glucose monitoring in the hospital, where you can monitor patient for glucose stability and whether or not insulin doses need to be adjusted, or other interventions, INR on-site for medication adjustment. And an example more recently is that the evolution from clinical laboratory-based PCR testing for COVID to our rapid PCR test, and then finally the home antigen test, all bringing information faster and ultimately right to the patient for diagnosis and care decisions. The issue we have is when choosing a centralized laboratory testing or point of care testing platform, which one provides the most total advantage? While centralized laboratory testing per unit may be cheaper, when you factor in the facilitation of the care process at the point of care, eliminate need for asynchronous messaging and follow-up because of a lab result, you can actually get to the point where the patient is provided a medicine or actual instructions at the time of their visit or interaction with the physician. If the point of care testing is acceptable, that offers the immediate available for decisions, that is critical. So both testing platforms require oversight, and the key points to evaluate are ease of use, cost per test, and can we really reduce the total resource consumption, including the people time of managing a patient's clinical problem with on-site results. So our point of care program is fairly robust. We got 12 or 14 different platforms and kits. We do over 360,000 tests per year across our system centered in Urbana at our ambulatory and hospital-based sites. We're supported by 4 FTEs and which are supported by the central laboratory lead technologists, managers, and physicians. So the issue is, how can we enhance our goal and standardize care to reduce unnecessary transfusions with using point of care strategies? This is important as we look back at the blood management work streams, optimizing coagulation. One of our challenges is to optimize coagulation in an actively bleeding patient. So specifically, we're talking about large volume transfusion scenarios that always require very intense support and laboratory staff, meaning multiple dedicated professionals, either in an operating room or an emergency room, in an obstetrical delivery bay, all need to cooperate and manage the patient with rapid response support. So these large volume transfusion events can happen anywhere. The massive transfusion protocol is a standardized approach to providing what is called a balanced mix of red cells, platelets, and plasma to mimic, to some extent, whole blood when patients are having active bleeding. Goal-directed therapy is another approach to managing the blood replacement in these situations, and that's where we use laboratory testing to basically provide us information on what products might be necessary or are not necessary. Viscoelastic testing or conventional coagulation tests for coagulopathy management. Since assessment of coagulation status is valuable and recommended for large volume bleeding decisions, options include conventional coagulation tests and viscoelastic testing. There are proponents for both of these platforms. Both can support appropriate clinical decision-making, but turnaround time is critical. Centralized testing for coagulopathy management in these events has, while it focuses the testing in the laboratory, has some significant drawbacks. Number one, you either have to replicate the laboratory at the site of bleeding, which, as you have shown, can occur in many different places, or you have to go through a system that orders a test and completes all the steps that it takes. Each of these involves a person, and people are not always available. And whether or not it's the person available to put the order in, the person available to draw the blood, a system or person to transport the specimen, removing the specimen, and preparing it for testing, result verification. As you can see, these are people that have to do things at each of these steps. It also adds anything this complex is subject to delay or failure at some point. So the more steps we have, the more chance of delay we have. The other thing we noted in our experience when massive transfusion protocols were activated, we had difficulty regularly getting samples that were recommended as part of our protocol. Despite multiple repeated efforts over the years, we were still unable to get testing that might give us baseline information about the current patient status or information related to the best choice of blood products. And when absent that, you make empiric choices. Viscoelastic testing or central laboratory testing for coagulopathy management then is the choices we can make in order to support emergent or clinical care. Combining point-of-care technology and viscoelastic provides an opportunity to reduce clinical resource consumption. Remember the significant resource consumption it takes to deliver a single urgent specimen to the laboratory and have someone available to test it and result it. It reduces errors and delays because, again, there are much fewer points along the process. And there's evidence that basically appropriate patient-centric care and blood product decisions are supported. So are they equivalent for clinical decision-making? In all likelihood, they are. What your choice relates to how you want to get the rapid results, whether or not you want centralized lab testing in multiple places or a single instrument that can be placed in multiple cases to give you the necessary information. So I think it's clear that VET is a recommended technology for supporting large transfusion events. Trauma, cardiovascular, and perioperative guidelines that include that viscoelastic testing is valuable and appropriate. So Carol's journey on viscoelastic testing began in 2012. We initiated a program using the HemoSonics TEG 5000 platform. It was based in the central laboratory due to the significant QC effort. It was not possible to have this out at the sites of the trauma bays and in the operating room and maintain the instrument and have it ready for use. It was primarily for trauma, general surgery. We had initially only a few physicians that were comfortable with interpreting the results, worked to create algorithms for interpretation. And lab-based VET had the characteristics of a central lab testing, where it was over 50 minutes for us to get a pattern, or a result back to the physicians. There were a number of issues with, again, getting specimens acquired and sent to the laboratory. The operating model required multiple instruments in order to achieve rapid testing results. And there were other issues that didn't support the growth. By 2016, we were using it regularly. We'd be using between 8 and 20 a month on patients presenting largely to the emergency room with trauma. One thing we noted was that the results were important. Oh, very important. Normal results were very important because of delays in care that were eliminated. By having a normal result, we were able to avoid delaying care. It was used in trauma area primarily, rarely for non-trauma cases. In 2019, we began looking for an updated solution that would eliminate our QC burden, which were significant, and improve turnaround time and allow easier access for laboratory results. And then COVID came along. I won't belabor the point, as we all know, we all experienced it. So in 2021, when we got our heads got above water again to some extent, I made a proposal to our clinical leadership of the various specialties that would be involved. They came back with a positive response supporting point-of-care viscoelastic testing. We received approval from leadership to develop the alternatives. In October of 21 began the comparison of two platforms, TEG 6S and HemoSonics Quantra. The evaluation included an extensive review of all aspects of the equipment, from its footprint to sample handling, QC, ease of use, ability to read the display, and certainly a big component was in our LIS EMR criteria for having access to the information. We decided after that evaluation that Quantra was a superior choice for Carl. Technically, it had major points that both the clinicians and the laboratorians identified. Was that there was no pipetting of a sample. A whole blood tube was presented directly to the instrument and walk away. TEG 6S required pipetting of a sample of whole blood into a test cassette. That in a busy operating room or trauma bay is a problem. Result viewing on the instrument platform was an improvement, although the TEG 6S has a viewing screen. As you'll see, the display on the Quantra is very user-friendly and interpretable. We also found it was easier to create results viewing in the EMR and combine the results from multiple different instruments. So the clinical users were uniform in their acceptance and endorsement of Quantra. As you can see, these are the two instruments. The TEG 5000 that we were using at the time, instrument is on the counter with a computer screen and computer also necessary along with a keyboard. Quantra is a self-contained instrument. The viewing of the results occurs on the screen on the TEG 5000, and on the TEG 6S, there is a screen on the instrument, and I don't think the computer and the keyboard are necessary. However, the view is fairly small. On the Quantra, you see the instrument there as a standalone, and as we look at the two way the results are presented, the TEG 5000 shows a screen, a tracing of a clot as it develops, and it reflects the interaction of the initiation phase, the acceleration phase, and the stabilization phase of clotting, and those are measured by parameters that are listed across the board that have normal ranges. The Quantra has a much more simplified viewing screen, which collects about clotting time, and in cardiac Q plus kit, we have the clotting time with heparinase, and then a ratio. And in cardiac surgery, where they use heparin during pump bypass, it's important to have the clotting time and the clotting time with heparin to make sure that heparin effect has been completely cleared from the patient after you remove, the patient comes off bypass. The clot strength below is a CS, it's a platelet clot strength is a PCS, and the fibrinogen clotting strength is FCS. You can see clot strength, it can change over the time of a case from high to low. As it does, you can see the different components. Platelets are fibrinogen, which then directs you to support in a bleeding patient who is trending down rapidly or has a low PCS with platelets, and it's similarly with the FCS low or trending downward rapidly in a bleeding patient, you would look for either plasma or cryoprecipitate. So it is directly interpreted, looking at this screen, potential contribution of a component selection. The Quantra also toggles over to a list that shows all testing done on that instrument, so you can see trends in the different parameters, either in a linear line trend or in a graph trend. Quantra has now 2 different cartridges. First is the Q Plus cartridge. The second is the Q Stat cartridge. As you can see, the Q Plus cartridge is approved for cardiac and major orthopedic surgery, and the Q Stat is approved for liver transplantation and trauma. I think it's important to note that these reagents are stable at room temperature, meaning you don't need refrigerator storage, and there's no pipetting involved. So with our experience, we began a capital process that got approved in March of 2022. We began an implementation that involved the Quantra team working with us to set up a schedule. They guided our validation and came on site and helped us with that. Our lab staff at this point in the process helped Quantra team understand the needs to meet CLIA and CAP requirements, as this is a moderate complexity test that requires degree staff in many cases, and we have to document proficiency. So we set up a process to identify those staff, make sure they were appropriately trained, and that we could document ongoing proficiency. We had an issue with the middleware vendor. We worked on that. After about 3 months, we were able to get that worked out and began on-site training and working with our nurses. We began cardiovascular testing in September 22, and we placed 2 instruments in the cardiovascular OR and 1 in the CVICU. We've continued to provide TEG testing for trauma during the interim. However, we plan to move on to the Q-Stat and hopefully in this July, as our connectivity issues have been resolved, and we're moving forward with that implementation. So clinically acceptance, we began in September 23rd, 2022. We've got 168 patients that all of them either direct coronary or cardiac structural or vascular surgery, or patients with complications. We've had significant positive feedback from the cardiovascular surgeons and perfusionists, and that they really feel comfortable with the testing and the results as they make their decisions going through a operative process and post-operative care. We've had great support of education and assistance in the OR, making them feel comfortable with the equipment. We've been seeing increasing use in the post-operative period in our ICUs, where any bleeding patient is assessed by the Quantra prior to triggering blood component therapy. In the past, we've noted that in the past there was frequent use of platelets and plasma in the postoperative bleeding situation, but that appears to be significantly decreased. And I think that may be attributing it to our use of the Quantras. We're attempting to validate that with some quarterly reviews of all activity, and I'm working with most importantly, we're working with the cardiovascular leadership and physicians to establish an algorithm and document indications for transfusion. I have to say, I think that's the one thing that this technology gives us, is it gives us a platform on which to develop an algorithm of which laboratory testing provides significant direction. That avoids random guessing as to what components might be necessary, which has been a common practice. So here's an example of what we're looking at. We're looking at basically the Quantra dials. They're easy to interpret. These patients, this particular patient on the upper left is basically a normal patient, pretty much. It shows that the patient has an elevated clotting time, which is a concern with an elevated CT ratio, which may mean heparin effect. And so that would be addressed. Below is an example of our Epic display that integrates all the testing in the different machines and gives you a chronological data set to look at over time to see the effect of a transfusion or other transfusion intervention. So I think this will prove valuable to us as we have more experience and more structure to our program, where we can see integrate our transfusion of blood components with what we see in the laboratory, as well as what happens as far as the patient bleeding is concerned. So we want to include a references that cite the use of Quantra and the value and compare value it has in different clinical situations. The literature reflects what we think are very appropriate representations of the use of the Quantra. A couple recent articles have appeared related to the Quantra use and its effect on blood utilization, which are generally neutral to positive. And a second article also shows pre and post Quantra blood use. Now it's real important to, I think the key thing, and for example, in this study, the change in the use of FFP, it was significant. I think in the past, a lot of people guessing were using FFP as part of a resuscitation effort without any real laboratory support. In these patients, if there's no evidence of a fibrinogen deficiency, we can avoid the FFP use. Well, in conclusion, I'd like to make a few points. There's a blood management imperative. Our blood donations are being challenged by changes in society, and a lot of effort is putting into maintaining donor participation. So the supply is limited. We need to reduce cost whenever possible, and if we can appropriately reduce utilization that is associated with blood products, including not just the purchase of the blood products, but the nursing and staff technical time that supports the availability of those blood products, that's a real benefit. We know we can reduce transfusions in appropriate settings without adverse outcomes to patients. Point of care technology can expedite care. And when we apply point of care technology to support an actively bleeding patient, we believe we can achieve savings in blood products and reduce transfusion risk and reduce our resource use across the organization.
Thank you, Dr. Wellman. That was wonderful. I appreciate that. That we all do. This is Jeff Light from HemoSonics. I wanted to open it up to the attendees to offer up any comments or questions. You're welcome to chat into the chat box. If you hover over the screen, a bar will show up at the bottom. You'll see the chat bubble that will open up the chat box. So you're welcome to join there. Alternatively, you're also welcome to unmute and speak up. Raise your hand or in any other way, ask a question. Thank you.
Jeff,
it would be great. Yeah.
Okay.
So, and to just introduce yourself.
Yes, exactly. Dr. Wellman, hi, it's Dr. Carolyn Burns. We spoke just a few minutes ago, and thank you for letting me be part of this. I'd be interested in knowing how you see that the fibrinogen levels or that composite portion that fibrinogen plays through the Quantra is comparing with your, perhaps if you're doing a definitive class fibrinogen in the lab. Are you reacting sooner to that decreased fibrinogen than in terms of waiting for your routine fibrinogen assay from your lab?
Carolyn, yeah, thanks for that question. We're looking at that now. Actually, we've got a database now of over 60 patients that we have profiled that compares the timing of the transfusions and the specific components with the laboratory. The clinical laboratory testing is typically done post-operatively, whereas they make their decisions intraoperatively based upon the Quantra for their components. I think we'll have a better idea. We're now seeing, we did put an instrument and train the nursing staff to do Quantras in our ICUs. So we're up to about 16 or 18 ICU patients where they'll get a post-operative laboratory coagulation test profile right after surgery. Then they go in if there's continued bleeding. Now we're seeing Quantra in much more proximate proximity to the results. So, I mean, it seems like when we do have a few cases where we have intraoperative laboratory results, again, I can see low fibrinogen. I can see him using cryo specifically, now more preferentially than FFP, but exact timing of trying to get them to identify the reason for their decision making is something that we're working on, so that we know when a decision is made somewhere, we can have it either relate to an algorithm direction or some documentation of a comment or note. So we're not quite at that, but as you know, the Hawthorne effect is a strong effect. And when you start sharing cases with a group of surgeons about their blood use, they become a little bit more thoughtful. So whether it's the lab test or the fact that it's being monitored, that'll be a challenge to separate out, to be honest.
Yeah. Either way, if it's working and it helps and is making better patient outcomes and better decision making, then good. So that's excellent. Good. Well, we'll be watching for some of your other data. Thank you.
Thank you, Dr. Burns. Speaking, Dr. Wellman, of data, I know that you've been collecting for a while, and wondering if you might comment on any other preliminary or anecdotal trends that you're seeing.
Really, Jeff, questions come up when we look at the data, and then we're trying to see what the timing is, and getting all that time information is correctly approximated to the actual administration time is a challenge. As we know what time it leaves the blood bank, it becomes a little bit more difficult in OR records to document the exact time of a intra intervention. We do note that when there's a abnormal, I can document that when an abnormal Quantra appears, there is a request for blood products. So I assume there's a relationship to the Quantra results and the decisions that are being made. And we just have to quantify how often that happens. We haven't been able to sit down and put all the level of detail in our data that I think we're getting to a point where we can make those adjustments, but we haven't done that yet. Yeah, you had mentioned in one of your final slides about working with the clinical disciplines, clinical areas to develop algorithms, and I would assume that all comes into play as you move forward. Yes, and I think as the literature, as we've noticed or noted, there are some algorithms showing up in some recent articles about the pathways other organizations have taken in their studies. They are observational single institution studies so far. So we'll have to wait and see. Intuitively, the surgeons tell me they use it to make decisions. That's what they say. I just like to document that we have a little more evidence to say how they correlate. And when there's something that doesn't correlate with it, what was the reason for that? So that's going to take a little bit more time. But in my experience with TEG in the trauma environment, even though we had delayed results, they felt it was very helpful. Towards the end, they were able to view on a much more rapid basis, but we still couldn't overcome the 20 or 30-minute delay to get the specimen in the laboratory and processing, because once the TEG tracing was started, they were able to view it eventually at various places. So they were very comfortable and used that as a way to guide their therapy. And the big thing is the outcomes, the number of large volume events you have, how many extended bleeding episodes you have while you're monitoring and intervening. Those would be the events we'd like to see reduced.
I have a question chatted in. This is a nurse from San Jose. Dr. Wellman, thank you. Can you comment on how your laboratory supports and encourages point of care testing with anesthesia and perfusion? In some institutions, that is not the case. And I suppose what that means is how did you arrive at this progressive thought that point of care is useful, and how might you also communicate to other people in your position and in laboratories?
Well, I've always, as you and I talked, Jeff, I've always been an advocate in our institution for point of care testing. When the astronauts took the ISTAT into orbit in the early 90s, I thought, heck, that's something we need, because we were replicating laboratories and struggling with stats, and more importantly, the football team needed to be managed for dehydration out on the training field in the summer. So we brought the ISTAT in, and now we got 87 sprinkled around the organization at this point. So when this opportunity came along, I'd been talking to the cardiac surgeons about using thrombo VET, but they weren't all that excited because it took so long, and we couldn't put an instrument in the OR because of the technology we couldn't support it. So they were on the lookout, and the perfusionists the perfusion group actually was very supportive of that. And they're in about 17 different hospitals in the Midwest. And so they see some hospitals that use it and some don't, and they were very favorably disposed to that. And then the nursing folks that we engaged on the critical care units were used to the fact that we had a lot of other point of care instruments out in the environment. So it wasn't new to them to take on a technology, which is basically a small instrument sitting up on their counter in the ICU that they would be using. And then we went through the usual training and supported them with proficiency testing. So our lab staff puts the program together. We go to the nursing. We all agree it's necessary. The nursing staff then gets the training, so they're comfortable doing it. And fortunately, the HemoSonic Quantra is a very user-friendly from that standpoint. And we will never achieve the sort of quality control that we utilize in many other laboratory testing on the floor. So it has to be simple. So I guess we were prepared from the cardiovascular surgeon standpoint. They were looking forward to it. They saw it in the literature, but until we got a point of care platform available, that wasn't really considered. The perfusionists already in their group were advocates for it and very much engaged. Now, anesthesia, some of the anesthesiologists came down. The younger ones have come from training programs where they have it, and they're interested in it. And when we get the QStat up and running, I'll be interested to see how that will work. And then that will also engage the OR nurses in the other areas other than cardiovascular surgery and training, as well as more frequent. We'll be using it in the emergency room as well. And so those nurses are all teed up. The important thing is don't start the training until you really have the equipment ready to go. We got everybody trained and then had a 3-month software delay. We're trying to avoid that, and we'll begin training hopefully soon as our software problems or our software issues have been resolved on the QStat. So we should be going on down that pathway. How do you make people do they're not interested in? I know I have a friend in Texas who's a lead national trauma surgeon who the pathologist won't buy into viscoelastic testing. I don't understand why, but for 3 or 4 years he's struggled to bring that into the organization. And so if there's resistance, I guess just by showing the multiple articles that support the use of the rapid testing would be the best way to start. You have to get a physician champion, I think, to push this into areas where make them aware of the advantages. To me, it's always been the case, whether it was an ISTAT issue back in the 90s or wanted stat potassiums or electrolytes or whatever, just the process of getting the lab specimen drawn, labeled correctly in a crisis situation, transported to the laboratory, and then set up for testing, and then getting results back to the right person. That is a huge diversion of labor. And today, with shortage of labor, I mean, we can't rely on people with wearing Nikes running around the organization to carry and deliver things. They just aren't there. And because healthcare is complex today, and there's a lot of stuff going on. So anything we can do to reduce that burden, I think the staff should be very supportive of.
Well, thank you so much for your time. I don't see any other questions. Any other questions in here? No?
Okay, thank you. Thank you very much.
Thank you so much, Dr. Wellman.
Right.